So we are used to think about myeloma as a disease of the bone marrow because plasma cells and also the neoplastic plasma cell resides within the bone marrow. But if you measure them with a technique that is sensitive, like the flow cytometry, you find that almost 90% of our patients have circulating tumor cells at diagnosis. So there are several reports showing that the levels of circulating tumor cells correlates with the prognosis of our patients. In this abstract, we tried to investigate the role of circulating tumor cells in addition to the standard of care staging system definition of high risk. So the last staging system that have been published is the revision 2 of the ISS, and this year the International Myeloma Society, the IMWG, proposed a shared definition of what we should call high-risk myeloma, and this staging system is called consensus genomic staging. So we investigated the role of CTCs on top of these two standard of care staging systems. So in the first part we focus on R2-ISS. So if you add CTCs to the R2-ISS, you improve your ability to do prognostication. So the performance of the models with the CTCs is higher in terms of PFS. And moreover, both the CTC levels and the R2-ISS predict the PFS in an independent fashion. So we demonstrated that if you stratify the single class of R2-ISS according to CTC levels low or high with a 0.02% cutoff, you end up with very different outcomes. The same you could apply to the consensus genomic staging, in which if you separate your standard risk and your high risk patients according to the level of CTC, you end up with very different outcomes. So our data suggests that you should include the measure of CTC by flow cytometry diagnosis in the new staging systems, and I think that it is now the time that CTC should be measured in all patients at diagnosis.